Well, hi everybody. Thanks for being here. It is, I always say this, you know what date it is, but for those of you who sing it at other times, well, it's already dated on the thing. All right, it's March 5th, 2021. Thanks for being here. We're going to talk a little bit about patient management today. Oh, there'll be some treatment planning too, of course, because these are treatment planning sessions, right? So we're going to talk about that. We're going to talk about why you decide to treat a patient and why you may decide not to treat a patient. And there's some criteria there, because sometimes we don't want to treat everybody that we see, do we? Or maybe there's some rules that we need to put in order to be able to make sure that the patients and we are on the same page. We're going to talk about those rules. We're going to talk about exactly how we treat a patient who may not be treating us exactly the way we want to be treated. And so as we go through this, you're going to hear some history. You're going to hear some things that I did, and I've never told you about this, at least on these sessions before. I'm going to talk to you about some perspective, particularly perspective as to who we are and what we can do and why we should do it, and you've heard some of that before. But I'm going to give you some of the background that got me to where I am right now and really got me to where I was for most of my career. So, okay, so you all know we do a lot of dental implants in the practice, right? You also know I believe in saving teeth. And both can be done and both should be done. And we've got to understand whether we should be doing it or whether we should not be doing it. I'm talking about saving teeth. And I'm going to talk to you about the fact that some teeth can be saved that we think can't be saved, and the only way you can do that is to give teeth a chance. Oh, we are saying enough. Okay, you've got to look. We've all got to be able to look and understand. Hang on, I got to shut the door. I'm sorry, I was almost prepared, but not quite. Okay. So we got to be able to understand who we are, and we got to be able to differentiate ourselves. Remember differentiation. We talk about differentiation a lot. I've talked about it. I've written about it for the past God knows how many years, for those of you who've been reading what I've written. Differentiation is important. Well, if the guy down the street, meaning the surgeon down the street, or the corporate entity down the street extracts teeth and puts in dental implants, and you do the same thing, and that's all you do, how does that differentiate you? How does it differentiate us as a profession? Okay, and the answer is, it doesn't. It doesn't. Now, we'll do probably 2 full arches a week. Maybe 1. All right, so maybe 1, maybe 2. Sometimes a little bit more, sometimes a little bit less, but, it's average 4, 5, 6, 8 full arches a month. I'm talking about full arch dental implant arches. But we do an equal amount of crown and bridge. Well, actually more crown and bridge. And we do a lot of perio. We get the idea sometimes it's a 100% thing. Oh, that tooth needs to be extracted. Well, you know what? How do you know? How do you know a tooth needs to be extracted? Okay, if the tooth is so loose that nothing can be done about it, yeah, that needs to be extracted. But what about the tooth that has disease? What about a large apical lucency? You ever seen a large apical lucency fill in after endo's done? You ever seen bone come back or teeth tighten up after perio's done? And so this idea that you've got so much bone loss, and we're just looking at a case and we're saying, there's so much bone loss, there's nothing we can do, we got to take out the teeth and put in implants. Let that be the other guy's solution. And if we have the opportunity of saving teeth, or at least proposing a plan to determine whether teeth can be saved, you can still do the other guy's solution, gal's solution. You've still got that. We're talking about not black and white. It isn't 100% the tooth needs to be extracted, or 0% tooth doesn't need to be extracted, or does need to be extracted. These are percentages. Okay, these are risks. And this is being able to communicate a risk to a patient who may have never had risks or opportunities for healing ever given to that patient. That's how we become doctors of the mouth. That's how we look at patients. Look patients directly in the eye and say, listen, this is what I think can be done. I'm going to show you how we go through that. Okay. So let me, I know what the next slide says, but you don't know it. So the history, okay. History was in, I think it was 1988. Okay, for 1988, I know is childhood for many of you, maybe earlier than childhood for many of you. For me, I'd been in practice as a periodontist for about 8 years. Okay, I'd been a general dentist and had gone through general practice residency for another 5, so I'd really been a dentist for 13 years, but a periodontist for 8. I went to the office of Dr. Perry Ratcliffe. Now, Perry Ratcliffe was former president of the American Academy of Periodontology, probably around 1970 or so. And I had seen him at a course run by somebody else. And Perry was talking about saving teeth. Now, understand our perspective at that time. Our perspective at that time is that we needed to go do periodontal surgery on nearly everybody who had defects. You had cratering, you had to get rid of the cratering with osseous periodontal surgery. Bone grafting wasn't that prominent. We were doing some bone grafting, no guided tissue regeneration in 1988. But, there were these moves, and they were starting to develop cortex membranes and things like that at that time to start to do epithelial exclusion in order to be able to regenerate an infrabony defect. So understand that was my perspective, the context at that time. Wasn't a lot being done, but it was being introduced. At that point, we didn't even know whether the bone grafting material was okay. Now they test bone grafting material. I'm talking about the bottled bone, the cancellous, cortical cancellous, the cortical bone. They tested for viability. At that time, they didn't really know how to test. They only knew how to test it for safety. As a matter of fact, at one time, probably during that time, for bone grafting, they were taking bone from cadavers that were of 50 years of age and younger, assuming that it was because you were younger, you would have more potential for bone to for the bone grafting material to be viable and to help in bone induction. Okay, so. Understand that's where we were at that point. Now there's efficacy tests so that, a 50-year-old cadaver can be horrible and a 75-year-old cadaver can be fine, but that's not where we were. So we didn't know whether the bone graft was going to work or not. We still don't know whether the bone graft is going to work or not, but even then, particularly when we're doing bone grafts that aren't around teeth, we didn't know. We just didn't know. We were doing things we were doing belt and suspenders approaches so that we wouldn't have to redo the surgery. And there were a lot of things that we were doing at that time to make sure we wouldn't have to redo the graft. But we really didn't know the potential for bone grafts. Sorry, I've said that 3 times. So I took a course with Perry Ratcliffe, or at least heard him lecture. I said, I got to see this guy. So I took one of my hygienists with me, and we went down to his practice in Scottsdale, Arizona. Now, here's what Perry was doing. And by the way, this was allowed. The hygienists were actually doing it. What they were doing was to take periodontally involved cases, and they were packing retraction cords into the gingiva. So you get the area numb, you pack the retraction cord into the pocket. Okay, and you keep on packing until the retraction cord has gotten to the surface of the pocket. Now the retraction cord was soaked first in citric acid. Okay, so it's regular retraction cord just like you use for crown and bridge. And if the pocket was deep, 7mm pocket, you'd put a lot of retraction cord in there in order to be able to fill that pocket. You leave that in place, I think, for 5 minutes, and then you take that retraction cord out and you put another retraction cord in, and this time it was soaked in a tetracycline solution. And you leave that in for 5 minutes. Then you take that out. Now you've got retracted tissue that's been treated with what? With citric acid. Okay, What are the effects of citric acid? You all know that, or at least we think we know that. So there might be some antibacterial effects. Certainly there may be some chelating effects. And then we're putting tetracycline, which of course is a bacterial effect, but tetracycline is also acidic, so there may be a chelating effect as well as altering the surface of the tissue, because we've got the tetracycline impregnated in that area along with the acid. So now we've taken out the retraction cords, and now we have retracted tissue. And now the hygienist can scale and root plane. This is before perioscopy. I didn't get the perioscope until the year 2000. So this is 1989. Okay, so what he's doing is allowing for complete visualization of the root as much as he can. So with retraction, mechanical retraction, chemical retraction. So then a good hygienist can scale and root plane her heart out. I suppose there's male hygienists, so her and his heart out until the root surface is clean. And then you just reevaluate the patients several weeks later and see how they were doing. And Ms. Perry's claim that most of these patients healed without doing our osseous periodontal surgery. Maybe without even doing any bone grafting. So I'd probably taken this course, right? We visited his office. It was probably October, November. So we go to we have our annual staff dinner, as we all have. And so we had, except this year. So we have our annual staff dinner, and it's at the Strawberry Mansion restaurant. And we're upstairs at the Strawberry Mansion restaurant in Melbourne. It's in a smaller room. We've got the hygienists, and we've got their husbands, and all staff and spouses and things like that. So it's probably, at that time it was relatively small staff compared to what we have now. So we probably had 8 staff members at that time, maybe 7, whatever it was. And so we do our dinner, and we do our awards, and we do our presents and all that kind of stuff. And then I do my speech. And my speech is usually speech where I say, hey, thanks. It's been a great year. Thank you for everything you've done. And we've got a brand new year coming up, and it's going to be even better. And I really appreciate you. Okay, the things that you would ordinarily do. Except I changed things. Oh, yeah, I gave them all the accolades. I said all the things you want me to say. They felt really good. And then I said, we're going to do something different in the year 1989. We're not going to do periodontal surgery. Instead, we're going to do what Dr. Perry Ratcliffe does. And the hygienists already knew what this is all about. And what Dr. Perry Ratcliffe does is to do everything non-surgically. And then he looks at the patient's healing response several weeks and months later. And we're going to do the same thing. And Rebecca, my hygienist, who'd been with me for probably 4 or 5 years at that time. Now she's been here for, 37 years. Rebecca said, we're going to go out of business. Well, that was great. Happy New Year. So the deal was this. So I would present this to the patient. Don't forget, this was all a referral practice at this point. We didn't have a magazine. We weren't doing any of the direct-to-patient marketing things. It was all referrals. And essentially what I did was I communicated the referrals as well as the staff and said, listen, we're going to do non-surgical work as a result of the demonstration that I've seen with Dr. Perry Ratcliffe. And then we're going to charge surgical fees. Okay, so we'll charge surgical fees. And if the patient needs surgery after we do all this, I'm going to do the surgery at no charge. And I told the patient that for each treatment plan. And essentially, we'd go through this Perry Ratcliffe plan for our patients for a year. Now, did I carry it out for a year? No, but I carried it out for a good long period of time, probably 7 months, 8 months, something like that. I had to do 4 surgical procedures to correct periodontal defects during that 7 or 8 month period of time. Now, at that point, we were doing periodontal surgery nearly every day. 4 surgical procedures. I learned a lot during that time. I learned that patients have the capability of healing if we just do the right things. And they have to do the right things too, okay? There's no question about that. And I found the bone came back, and I found the teeth tightened up. And we weren't using systemic antibiotics at that time either. We were just doing what I told you. Pack the cord with citric acid, take that cord out. Pack the cord with tetracycline, take that cord out, do the scaling and root planing, and then observe. That's what we're doing. We see the patient for reevaluation about 6 weeks later, which we still do today. I don't make any decisions unless they're emergency decisions for at least 6 weeks after we've done periodontal treatment, and usually a lot longer than that. Perioscopy has made things so much better because we can see the root surface better. We don't do the retraction anymore. We've got the scope and we can see the roots if you have a good hygienist. Okay, I mean that's not every hygienist can do perioscopy. They can't. I know that here. I mean, for years it was only Rebecca. Now it's Rebecca and Amanda can both do it. But it's only Rebecca. We've always had two hygienists, sometimes more. It's only Rebecca who could do this and do this well. So understand, it isn't just the scope, it's the ability to use the scope. But I digress. We go back and we see the patients 6 or 7 months later, and they're growing back tissue. They're growing back bone. Teeth are tightening up. Etiology of the disease is gone. The patients heal. And we didn't go out of business. In fact, our numbers in 1989 were about exactly the same as 1988. So we didn't have growth, but we didn't decline either. And then that set the stage. Now I knew what a hygienist could do. Now I knew how well non-surgical perio could be. Then I started going to school for dental implants. Really big time. Dental implants, bone grafting, everything under the sun, because now I knew the hygienists could get periodontal disease under control. And they could. And then 10 years later, we get the perioscope, and it improves things even more. By the way, we started doing more guided tissue regeneration as some of the membranes came out and some of the bone grafting materials got better. So don't think I wasn't doing periodontal surgery where I felt it was advisable, and particularly at that time we didn't have the periodoscope. So despite the packing that we might do of a 7, 8, 10 millimeter pocket, we still couldn't see to the base of the pocket at that point. And so I had to go in there surgically and clean it out and do the bone grafting and stuff like that. That's where we were then. Most of our chronic perio stays under control without ever going to us. Yes, we have a laser and we'll use it when we're not successful. But understand with the oral DNA that we do and the antibiotic, systemic antibiotics, which are targeted very well, or the bacteria is targeted very well with the oral DNA test, and good, thorough root debridement, most of these patients heal. Okay, occasionally we have to go back because we can't see it, and the hygienist can't see it either. Or there's root anomalies, or there's something you all know. But that's where I get my perspective from. And so despite the fact that we've got a very, very high producing office, and we do, understand that high producing office doesn't mean that because you're a non-surgical periodontist treating perio, doesn't mean that you can't be a very successful aggressive surgical person when it comes to doing dental implants, making sure that we have enough bone volume, enough bone density, and doing those things we need to do in order to be able to make sure that that part of it's going to work okay too. So patients are capable of healing. And as you see today's case, that's the perspective I want you to look at. Okay? Now there's a patient management thing going on here as well. And someday I'll show you cases. This is a treatment planning session. I don't go back to prove my point. If I have to prove my point, well, maybe you shouldn't be watching me. Maybe I'm totally making everything up, but what do I have to gain at this point? I've had my career. I don't do clinical perio anymore. I do examinations only. Things are going well. But I'll show you some cases. I'll ask the hygienist to find some cases and show you that. But that in fact aggressive perio or severe perio can heal. So at least get in your mind that maybe the decisions that we make on extractions don't have to be made, or they don't have to be made right now. And then we'll talk about a few other things along the way. Oh, I went long, 20 minutes, my goodness. Okay, so here's the patient. So here he is. And let's go over what happened. So here's the intake call. Jennifer takes the intake call. It was referred from Dr. N. Now, I've never worked with Dr. N before. Okay, and the patient needs a periodontal consult, and he's scheduled for February 17th at 11:30. Okay, I do the doctor call, and what happens to the doctor call? Nothing, so I leave a voicemail. I don't, I will give the opportunity for the patient to call back sometimes. And sometimes I do when I made a call. But, I'm not going to keep on making doctor calls. I'm making the doctor call so they hear my voice. It's something nobody else does. Again, you're differentiating yourself. As soon as you make that doctor call to welcome the patient to the practice before the patient ever comes in, don't you think that makes a difference? What other doctor does that? What other dentist does that? What other anybody does that? And it's a call from you, not from a staff member. Yeah, it's a good thing. Okay, so here's the system notes. The patient arrives on February 17th. It was referred by Dr. N to us for perio. Patient doesn't remember the name of the dentist, so he remembered the name of the corporate group it was coming from. Wants evaluation. The first and it went for evaluation. Not want for evaluation. Went there for evaluation. The first visit, they referred him straight to us. Don't even pass go. Don't even go through anything. Go directly to the periodontist. We took a CT scan, a series of X-rays and photos. Patient arrived 30 minutes late. Well, if the patient arrives, here's the way we schedule things. The way we schedule things in our office is this. So we schedule things with 40 minutes for the 40 minutes for the patient to meet with the assistant, do medical history, take all the X-rays, CT scan, everything else. Okay, it takes about 40 minutes. Then the next part is 30 minutes with me and the assistant. Okay, and then there's another hour where the assistant goes over the different treatment plans that I talked about and how much it costs and gains treatment acceptance, or at least gets the point where the patient has full understanding of what occurred in the operatory. Okay, so the patient comes in 30 minutes late. What's left? Well, I can't do much until I get data, and I won't do much until I have data in front of me. So I want the X-rays in front of me. I want the CT scan in front of me. I want all of that stuff in front of me. Well, there's not enough time for Laura to get that. So what Laura says is, okay, I will get all the data now. So she'll take all the scans and medical history and blood pressure and all that kind of stuff, and then we'll reappoint you. Okay, we'll reappoint you for another visit. At that point, you can see Dr. Sheldon. Okay, so that's what we do in order to be able to stay on schedule, and so that I'm providing a service that I think is going to be worthwhile for the patient. Now, the patient says that he's always running late, and so he said, all right, I know I'm supposed to come in for 11:40. Give me an appointment card for 11:10 so I arrive on time. Okay? So he even knows he always runs late. He comes in on March 2nd. He arrives 20 minutes late. Not 20 minutes late for the 11:10 appointment. 20 minutes late for the 11:40 appointment with me. That's all we're doing is an appointment with me. And so he arrives at noontime for the 11:40 appointment when it said in his appointment card, what? 11:10 a.m. So Laura comes up to me, tells me what's going on. Laura says, go do the examination. I will educate him about arriving on time during the financial arrangements appointment. I said, no, I'll do it. And so I did it. So I met the patient. What did I say to the patient? I said, Joe, come on in. Yeah, or I'm not cutting him. He's already in there. Hi, I'm Lee Sheldon. Thanks for coming. Before we start the examination, I got to tell you something. You're 30 minutes late for the last appointment. You're 20 minutes late for this one. If you're going to be late, if that's the way you operate, I can't see you here. You'll need to find somebody else. And then I say nothing, just like I did just now. When's he going to say something? Non-communication, or at least non-verbal communication, can be just as effective as verbal communication. Sometimes more. That's all I said. And he said, I won't be late again. Now, he could have said, you're a jerk. And I'll say, fine, I'm a jerk. Well, you'll find somebody else who's willing to live with your schedule, because dentists aren't that busy. And that's what you're saying to me right now, but I'm not that busy. I can't offend a patient. I can't offend a referral source. You know, one of the biggest advantages of being able to control your patient flow is to be able to do exactly what I just did with Joe. What I did this week. I don't care if I don't get a referral. Now, of course, I'm going to communicate with that dentist the first time he's ever come in. I'm going to communicate and I'm going to talk with him and let him know that. And you should too. Because if he's doing that to me and he already says he already runs late for everybody else, what's he doing to that dentist? So essentially you're letting the patient run the show rather than me. And I decided a long time ago, man, I wasn't always this way. I decided a long time ago that wasn't going to work. So the communication has to be kind, but the communication has to get there. Now, why do I have the confidence to do that? And it's what I said before. I control my patient flow. You know, I'm not just dependent on the referral source. And if I want more patients, I send out more advertising. I mean, that's essentially the way it works. So when you can control your patient flow, you can operate from a position of confidence. Now, if you're not seeing enough patients, then you have time to see a late patient, don't you? But understand that when you're seeing the patient late, you know how you feel. And you know how you may run late for the rest of the day to accommodate that one patient. Is it worth it? That's a decision. You know, you control your own reality. You're the one who decides what your life is going to be. It's not the patient. We're not going to be victims of our bad patients. At least I'm not. So, but communication has to be open. So we have to tell the general dentist that. And the general dentist might very well say, you insulted my patient. I won't refer people to you anymore. But you know what? The general dentist is more likely to say, thanks for doing that. I wish I could do that, but corporate doesn't allow me to do that. Okay. So you can keep the communication open. Now, if you're not ready to do that, and you need to communicate with the general dentist first before you set your standards, by all means do that. But don't be, if you're a victim of this, then you become a victim of insurance companies, a victim of everything else, and the victim of your staff. You're not willing to confront your staff. You're a victim of everything else, and things don't run the way you want it to. I mean, who knows how to run your practice better than you? So we've got to look at that and understand that we can take control of the situation. I didn't get mad. Just told him what it is, what it's like here. And if he shows up late again, he'll be discontinued as a patient. That's just the way it'll be. Okay. So it's not a threat, and then you don't go through with the threat. It's, here are the rules. You violate the rules, you can't be a patient of mine. And I've done that. You've done that too. You've discharged patients. It's okay. Nothing wrong with that. Okay, so I talked with Joe at the time of the examination. He said that he had a long way to drive. That was his first excuse. I told him he needs to leave enough time for that drive. And he should arrive here 10 minutes early that we can't see him if he's late for his appointments. He understood and said he would arrive on time. We then proceeded with the examination. And we did. Everything was friendly. Everything was fine at that time. So there's Joe. So let's take a look at all of his pictures and see what we know about Joe. All right, you see the areas of caries. You see the plaque. You see the calculus. You see Joe, who's been without dental care for, I forgot how long. I mean, it's obviously years. Okay, big area of decay on tooth number 19 on the facial aspect. We'll lighten that up a little bit so you can see it. And we have some decay. You'll see decay on 31. Notice 31 is not in function. It's barely in function. See that broken tooth? Tooth number 5. Yeah, it's 5. 4 is broken. Below the gum line, we take a look at the lower. There's tooth number 31. Tooth number 31 is in good shape. So, or it's in bad shape. So there we are. We've got that area on tooth number 18 that's carious. 19 that's carious as well. Okay, let's take a look at the X-rays. So as you're looking at this, I want you to look at caries, because a lot of you are periodontists. I want you to start looking at caries if you're not doing it already, and start to define the surfaces that need to be treated. You can do this. All right, so you see distal decay in tooth number 3, you note it. Tooth number 4 is non-restorable. Tooth number 5, probably not okay. 6, you see what you see. I'm going through this rather quickly. You see an infant bony defect. Number 9, number 10 is infirmitus and barely has any bone support. 11 is not bad. 12 is a disaster. 13, there may be something to it. 14, there may be something to it in the presence of what's likely a class 3 frication. On the lower arch, okay, look at the bone support you do have. Don't look at the bone support you don't. Same with number 20 and number 21. Look at what you do have. It may not be great. There's 22, which is blocked out by the torus. You don't see all the bone. There's 23, 24, 25, 26. Look at the bone that you do have. Okay? Space between 27, 28, 28, 29, 30, and 31. And remember, 31 is not a function. Now, Joe doesn't have very much money. You know that just to look at him. Okay, more caries, distal tooth number 3. Just note it. Just note it. As a matter of don't just note it. Note how you would do the restoration. You might do a DOB or a DOL, whatever it is. Note that. Because we want to provide a restorative treatment plan and start to fine-tune ourselves so we can help out our general dentists. Okay, so now let's take a look at what else do we have here? Yeah, let's look at the CT scan. So remember, CT scan every patient. I've got the CT scan sitting there. It's collecting dust. If it isn't used, use it. You can see periapical lucencies. You can see ridge width. You can see a lot of things. And of course, we don't charge for that. Why? I determine my treatment this way. Patients are not willing to pay for diagnosis. They're willing to pay for treatment. They're willing to pay the internist for diagnosis, not the dentist. Take a look at the bone support. There's bone support all the way through here. How much of it is subject to question? There's 10. I agree with that. 10 has no bone support. But 11 does. 12 doesn't. 13, there is some bone. 14, big class 3 frication. There is some bone. Okay, we'll look at the lower. You'll see the area of caries in the distal and the facial of 19. There's 20, bone. 21 has bone. 22 has bone. 23 has a little bone. 24 has a little bone. 25 has a little bone. 26 has a little bone. In other words, the tooth hasn't fallen out yet. Right? 27 has bone. 28 has bone. 29 has bone. 30 has bone. And 31 is not worth spending any money on. After all, it's barely in function. You're not going to spend $3,000 plus on a tooth like that to do endo, build up, and a crown. And it's a lot more than $3,000 plus for many of you, depending upon where you're from. Okay, so even here, this would be more like a $3,500 treatment plan to save tooth number 31, and 31 isn't in function. Why would we spend that kind of money on a tooth like that? Of course we wouldn't. Right? Let's move forward. So there's a periodontal chart. Okay, now I didn't do the period chart on the upper. Why? Because we are taking out the upper teeth. There isn't enough restoratively. We're going to lose tooth number 7. We're going to lose other teeth, tooth number 12. What are we going to do? I mean, I give up on the upper arch. We can wear an upper denture, and a patient can do fine with an upper denture. And so I give up, particularly when we have 3 and 4 mobilities on, let's see, you've got 2 teeth on the upper. If we take a look right here, there's a 3 mobility on number 5. There's a 3 mobility on 12, and a 4 mobility on number 10. 4 mobility is a 3 mobility, which is a disaster mobility, so I call it a 4. But 3 mobilities are essentially teeth that I don't feel are savable. Okay, but take a look in the lower arch. Take a look at the lower arch as you go across here. Okay, 8 to number 19, 1 mobility, then 2 mobility. I don't know why we don't have any mobility on tooth number 21. Maybe there was no mobility in 21. Maybe that was it. 22 had a 1. 23, 24, 25, 26 had a 2 mobility. Okay, there was still something holding them in. Okay, tooth number 28, 1 mobility, 29, 2 mobility, number 30, 1 mobility, and 31, which I didn't even probe because I knew we were taking it out, had a 2 mobility. Okay, so that's where we are. Now, I find this to be really useful. This is not Joe. Joe's subgingival microscopic sample looked worse than this. He had a lot more spirochetes in there. And I'm not going to make a diagnosis from this. We've talked about this before. I know there are others who think they can make a diagnosis from this. I don't think they're right. But that's, they think they're right. That's their reality. It's not my reality. For me, I want to send a bacterial sample out to the lab. I want to find out what's growing there. And as opposed to others who say this might be something other than bacteria, I don't have that belief. I could be wrong, and they could be totally right. But that looks pretty good, doesn't it? Okay, a microscope doesn't cost that much, by the way. You can get into a microscope for, I don't know, $5,000? Maybe it's more. Maybe it's a little bit more than that. But pretty good. I mean, essentially take a sample of the probe, and you take some saliva on there, and put it on the slide, and put a cover slip on it, put it under there, and you show this. The show is actually worthwhile. A lot of patients are motivated by that show. They see something, and they understand what periodontal disease is all about. At least they find out what the bacterial portion of periodontal disease is all about. It's important. Okay, blood pressure is decent. pH level is 5.5. We do pH levels, on every patient. Every patient has a 5.5. That's a pH level, meaning there's constant demineralization going on the tooth, or it's likely that's what's going on at a pH level of 5.5. Okay, intraoral is lower lingual tori. Got an angles class 1. This femorous 4, 5, 12, and 13 overbite is 20%. Overjet is 0. There's crossbite on tooth number 3. Evidence of light wear. That's actually attrition. No effraction. There's erosion numbers 3, 5, and 6. TMJ, there's a late open click on the right side. I don't know why it's open REC, but it's an open click on the right side. So when he opens at the full opening or almost the full opening on the right side, I feel a click. I want to know TMJ. Why? It isn't because we treat TMJ. We do some, but not a lot. I want to have that as a record in case the patient says, my jaw is clicking now. And I have a record that says, no, your jaw was clicking when I saw it for the examination. Same reason why I want to do a maximum opening of 58 millimeters. I want to know if the patient has trismus and was able to open to 37 millimeters, I want a record of that in case the patient comes back and says, I can't open my mouth as much. Well, open your mouth as far as you can. Okay, it's still 37 millimeters. Okay, so I want that record. Mallampati score, we talked about for sedation. Palatal vault is normal, and the gingiva is inflamed. So let's take a look at this patient. What do you want to do with this patient? All right, I've already given you a hint that I want to take out the upper teeth. Okay? I want to take out the upper teeth and do a full upper denture. And by the way, you have some indication on these lower teeth that there's a bit of super eruption on numbers 23, 24, 25, 26. And I also know the tooth number 10 is infirmitous with likely tooth number 23. That's part of the reason for the mobility of that tooth. I know that. And we know the number 31 is going to come out because it's not worth spending money on. So we'll take that one out. But what about the rest of these teeth which have 1 and 2 mobilities? Can we take number 19 and can we restore that tooth? Yeah. Might not want to spend the money on endo, but you might want to say, hey, to the patient, it may be worth saving this tooth. You're biting on this tooth. Okay, it's a molar tooth. I wouldn't spend the money on the root canal, but you might want to see your dentist and see if the dentist can remove the decay and put a filling in. And if you get a toothache, then extract the tooth. Okay, so understand the dentist is going to do the best job the dentist can do, but the decay is deep. You see how close it is? How close it is to the nerve? You know, you may not be able to save that tooth. And it may cost you $300 or $400 to find out. Okay, if you're okay with that, then it may be worthwhile saving the tooth. And if it doesn't hurt, then you get to save the tooth. And if it does hurt, then, all right, you're not going to spend the money to do the root canal, which is going to cost you about $1,500, and to do the crown, which is going to cost you another $2,000. So you've got to be willing to spend, so you give them, is it worthwhile spending the $400 to decide whether we can save the tooth? Find out from your dentist how much it's going to cost. I'm giving you a number of $400. Don't go by me. Okay, I don't even know if my number is correct in our own office. And then the patient says, well, yeah, I'm willing to spend $400 to find out. And if it doesn't work, we're going to extract it, and it's going to cost $300 to extract the tooth, okay? Or he says, I can't afford it. All right, then let's just take out that tooth. We're giving the patient the choice. We're giving the patient real informed consent. We're allowing the patient to decide what he is willing to do and what he isn't. But the rest of the teeth on the lower, I've already made up my mind. You already got that we're going to try to save the teeth. Now you'll say, what about number 23, 24, 25, 26? And what I'm going to say to you is this. The patient is scheduled in our office for 2 hours of root planing plus a 1 hour reevaluation. And we're going to do it by perioscopy. 23, 24, 25, and 26 are pretty easy to clean. He's got a lot of recession on there on those teeth anyway. Is it going to cost the patient any more money to treat 23 through 26 than to extract 23 through 26? And the answer in my office is no. That my hygienist should be able to get those teeth totally clean in a 2 hour period of time. Now maybe yours can't, okay, but mine can. And you might have to schedule some extra time. And I tell them, I'm not sure about 23, 24, 25, 26. You know, you may lose them no matter what. But it's not going to cost us any more money to find out because we have to treat the rest of the teeth on the lower arch anyway. So what do you think, Joe? Should we try to save the lower teeth? What's Joe going to say? If you take out the teeth, he knows he has to wear a partial denture. Or a fixed bridge maybe, but that's not in the cards for him. So, of course, we hope and anticipate the patient would say yes. We get a couple of things. Number one, we find out the patient's ability to heal. And by the way, if these lower teeth are infirmitous, take them out of occlusion. You're going to have to take them out of occlusion for the denture anyway. If those are super erupted right here, you know, in order to be able to make the denture fit properly, you're going to have to flatten those teeth anyway. Flatten those teeth. All right. Cost some money. Might do it during the hygiene visit while the patient, but during the replaning visit while the patient is numb. That's fine. So you take some diamond burrs, start off with a red diamond, get them where you want, then finish them up with a gold diamond or with a flat white stone, and just get those teeth at the correct position. Now you're taking those teeth out of infirmitous, and while the patient is waiting for the upper denture, you're taking the upper teeth out of infirmitous as well. Okay, now we've got a better chance for them to heal. You want to split the teeth? Oh, even a better chance for them to heal. Okay, I'm not talking about splinting here. I don't know if it's worth spending the money in the splint. And for me, I'm concerned that the patient's going to bite down the wrong way and he's going to break the splint. So I would rather not do a splint in many cases. That doesn't mean we don't place splints. We do. But But if I'm looking at the patient's ability to heal, let's take the teeth out of function. That's enough of a splint for me. May not be enough for you, but it's enough of a splint for me to be able to determine whether it's worthwhile saving those teeth or not. And on the upper, we're going to recommend extraction of the upper teeth with a temporary denture. And that will be followed by a permanent denture that will be constructed about 6 months later, something like that. And that's the way we'll treatment plan them. And I'll treatment plan everything. Of course, we do with the restorative in our office. No reason why you shouldn't give the same treatment plan. And let the patient hear from you, as I've said to you on a number of occasions. Let the patient hear the whole treatment plan from you. Well, I don't know the fees. We'll find out the fees. I don't know if the other doctor wants me to present the treatment plan. Find out from the other doctor whether he or she wants you to present the treatment plan. Okay? Open communication. If the doctor says no, then don't do it. We'll return to your doctor and he or she will be able to give you the treatment plan. Okay? Just do it that way. Okay? Let's see if there's anything else on this. Okay, so here's the letter. I write to Dr. N. Thank you for referring Joe for evaluation. Joe has severe periodontitis, both the upper and lower arches. He also has caries as well. I won't list the caries in the upper arches. There aren't enough good teeth to be saved in the upper arch. My goal, however, is to be able to save sufficient teeth in the lower arch that at least it can function without a partial denture. The areas that I would recommend treating in the lower arch from a caries perspective are the following. Number 19, if you can do a pulp cap on that tooth and put a 3-surface restoration, it has good bone support and maybe we can get some time out of it. If it's going to require endo and a crown, it's not worth it. I've let Joe know that you're going to do the restoration above, and if he gets the toothache, then we'll take out the tooth. Or or the dentist can take out the tooth. I don't care. If we are able to solve the problem number 19, with a conservative restoration, he'll keep the tooth. So we also have the following areas. Number 27, mesiofacial root caries. Number 29, mesio root caries. Tooth number 31 is the only tooth in the lower arch that's not savable. But periodontally it is, but it would need crown lengthening, endo, and a crown. And it's just not worth saving the tooth. And the upper arch, the best choice to go to is an immediate upper denture. The lower arch has aggressive periodontitis with high accumulations of spirochetes in those areas. Spirochetes is not diagnostic of anything. I just said it. But I put it in there. Because we look at a microscopic sample. Why not say it? My recommendation on the lower arch from a periodontal perspective is the following. Number 1, oral DNA test. I love oral DNA test. If you haven't tried the oral DNA test by now, come on. Try it. The diagnostic you get from that, just fantastic. Okay. Determine the bacteria is present. Number 2, appropriate antibiotic. Okay. Bacteria is invaded into the tissues. You could say, I can get rid of it with a laser. Yeah, you probably can. You can say, I can get rid of it with ozone. Oh, you probably can. Right now, I'm on systemic antibiotics. I don't know why we're so big on systemic antibiotics every place else in the body, but for some reason, the mouth, we say we don't need it. What's going on with that? Okay, I mean, I understand what happens with gut bacteria. I know all of that. And I suppose in a patient who was a health food person and never takes anything, and yeah, I would certainly work with that patient and say, all right, I can do this. Here's what I feel. I'm certainly willing to scale and root plane the teeth and see how they do. And then if we need to, we can go back and do another oral DNA test and see how it does at that point, or maybe doing our first oral DNA test after we've done the gross debridement, and then you do the best you can with whatever you're going to use, clove oil or garlic oil or oregano oil or whatever oil you're going to use in order to be antibacterial. That's fine. I'm willing to work with the patient. Well, scale and root plane, it's another 6 weeks. I'll know how we've done. And then if we're not okay, say, all right, we've done everything we can. You've done everything you can. How about if we do the oral DNA test now? And now, will you please go on the antibiotic? And at that point, the patient will say, yes. And listen, I'm very much into alternative medicine, so understand that I understand that side. I've studied that side. I work with alternative medicine practitioners. I'm going to be seeing one in an hour and 20 minutes. So I got that, okay? So then we do non-surgical perioscopy on all the teeth, number 19 through 30. We do a periodontal reevaluation. If the periodontal reevaluation is as good as I expect it will be, and given the fact that Joe has decided to stop smoking, I think we have a good chance to save most, if not all, of the lower teeth. Despite the fact they've lost so much bone support. How long will that happen? I don't know. I can tell you, unless we try to save the teeth, we don't know either. And the good news is he's already reduced the smoking from 2 packs a day to half a pack a day. And he's on his way to 0. And so the etiologic factors, the bacteria is gone, the calculus is gone, he's getting some treatment, maybe we're using an antibiotic, and he stopped smoking. Could heal. No, you're not going to grow back all the bone. No, you're not. And 23 through 26 may be lost anyway. All right. When? I don't know. Next year? 5 years from now? 10 years from now? Never? I don't know. I know he's going to be functioning against an upper denture because there's going to be less stress on the lower anterior teeth. So if you're looking at occlusal trauma, that can be pretty much be mitigated or can be gone. After you've received this, let's talk. I'll upload the CT scan as well as the full mouth series of radiographs so we have everything to look at, and then we can talk and coordinate for the treatment plan. In the meantime, we will start treating the periodontal disease in the lower arch. Note, you may want to consider leveling the lower incisors in order to be able to develop a more confluent occlusal plane on the upper arch. I'll leave that up to you, but I'll be happy to talk you through that if you'd like. He's a dentist. He's young, I know that. Note number 2, Joe has decided not to take out the upper teeth and wants us to clean them instead. I won't do root planing there. Okay, let's get off this because we've been going for a long time already. I won't do root planing there. But will I polish the teeth to make him happy? Yes. Unless there's an abscess that's going into a vital structure. In other words, if there's an abscess that's going into the sinus, no, I won't do that. I won't agree to that. But here we've got periodontal disease, and it's not destroying vital structures yet. And so I'll go along with him for now, knowing that I've established a relationship with him, and with that relationship is the opportunity for success. So how are we doing with all that? Are there questions? Do you ever use the Miller-McIntyre score to discuss prognosis of patients? And the answer is yes. I was using it. P.D. Miller and I have a relationship, and I was using it for a while. I was, and I think it can be a very successful communication tool. If you want to know more about the Miller-McIntyre index, just look up P.D. Miller on Google. He has a beautiful virtual textbook. It's all online. And he's done a beautiful job with it. And it will educate you on the Miller-McIntyre index, which is far more valuable as far as I'm concerned than the AAP classifications of 2000, whatever it was, 17, 18, 19, whatever it was. Far more communicative because essentially what PD did was take his patients over his career and looked at them in a number of different ways, including smoking and calculus, the amount of bone loss, and all that kind of stuff, frication involvement, and he was able to set up an index which would predict how long the teeth would last. You have an 85% chance of these teeth lasting for 10 years, a 65% chance of it lasting 15 years. It's really good. And it won't take you long to learn the MMPPI, is that what it is? Yeah. Miller-McIntyre Periodontal Prognosis Index, I think it is. So, yeah, look at that. Any other questions? Yeah. All right, good. No session next week. But the next session will be on March 18th. That's at 8 p.m. I'm sorry, 9 p.m. Eastern. 6 p.m. Central. So that's a 6 p.m. Pacific. So that will be on a Thursday night. I will send you the link so you'll have all that. We'll be meeting. I'll be giving a lecture to a study club, and we'll be talking for 2 hours at that time. It'll be a 2-hour session. We'll talk about the entire examination sequence and how we do it, as well as to go over a case, and it's likely going to be either this case or the case we did last week. Okay? Thanks. Have a great weekend. See you on the 18th. Bye-bye.